Good morning and welcome to Pediatric Grand Rounds. It's my real pleasure today to introduce our two Grand Round speakers today, who are colleagues and friends who are going to be speaking to us on a critical topic in pediatrics. I'll first introduce Chad Hermann. Chad is an award-winning writer, editor, and filmmaker and teacher with a national reputation for communication in both healthcare and academia. He's consulted for a wide variety of clients, including nonprofits, advocacy groups, political candidates, and Fortune 500 companies, and most recently served as VP of Communications for Pediatric Associates family of companies. In 2021, People magazine named him a national vaccine hero for his work in health and science communication. Before working in healthcare, Chad, as he will always say, was a recovering academic who taught at Carnegie Mellon University's Tepper School of Business, where he was named by Businessweek magazine as one of the top 25 undergraduate business professors in the country. He's joined by Dr. Todd Wolynn. I've known Todd for his 30-plus years in pediatrics, and he has great experience in primary care, in vaccine research, and especially more recently in public health advocacy. He co-founded Kids Plus Pediatrics in 2010 in our area, served as its CEO for 12 years, and led the practice to nationally recognized expertise in innovation, patient engagement, clinical quality, and I will add to this, defense of vaccines. Todd most recently served as VP of Medical Affairs and Communication and Integration for Pediatric Associates family of companies. In 2019, he co-founded Shots Heard Round the World, a nonprofit dedicated to protecting the online safety of healthcare providers and practices. For his pioneering work in healthcare innovation and science communication, Todd has been named an EY Healthcare Entrepreneur of the Year, a People Magazine National Vaccine Hero, and an AAP Holroyd Sherry Award winner. I can't think of a more important topic in a time where we battle misinformation with great communication than to hear from Chad and Todd today about the messenger is the message. So please join me in welcoming Dr. Todd Wolynn and Chad Hermann.
I'm going to begin with a disclosure. I am a Philadelphia native. Wow, that was harsh, but well-deserved, and a Pittsburgh transplant. And I will say that I have met George Romero, I have introduced Rick Seebeck, and I have now been introduced by Andy Nowak. I'm not sure there is anything more for me to accomplish here in Pittsburgh than that. I have basically hit my bucket list. I'm Chad, he's Todd, and as Andy already told you, the topic of our talk today is the messenger is the message. If that phrase sounds sort of kind of familiar to you, I'm guessing you have heard or seen at some point a phrase, the medium is the message. That was coined in the 1960s by a communication theorist named Marshall McLuhan. And his idea then, still incredibly relevant today, is that the medium through which a message or a piece of information is communicated fundamentally affects the way that message is received by its audience. If you don't believe that, think about the difference between reading something in, let's say a newspaper while we still have one. Too soon? Is that too soon? Too soon. And say on TikTok or on Facebook or on the platform formerly known as Twitter. How we get information is incredibly important. That's sort of the bad news for us here in the age of algorithms and online fueled outrage. The good news, though, is the title of this talk, which is that another communication theorist working several millennia before McLuhan understood, his name was Aristotle, perhaps you've heard of him too, understood that the messenger of the message really can be the message. And we're going to talk to you today about how, as healthcare providers, this has, in an age of increasing skepticism and declining trust in literally everything and everyone, you all are the antidotes. You're the exceptions. Again, he's Todd, I am Chad, and we are from the Trusted Messenger Program, which is a nonprofit that in our fancy sort of one-liner is it empowers healthcare providers, health systems, and integrated delivery networks to drive quality outcomes through the practice of evidence-based communication. In a more tangible way, it means that what we are doing is teaching people who have, how many of you have ever in your careers, received formal training in communication? Okay, four and a half hands, which are about 3.5 to 4.5 more than we normally see when we ask that question. More on that in a minute. But it means that we are trying to talk about that and address that in any way that we can, because we believe, we actually know, as we're going to tell you again throughout this talk, that good communication is essential to good healthcare. In fact, we're going to go so far as to argue that communication skills are the single most important skill that any healthcare provider has. You can walk into an exam room or have a patient encounter, and you can nail that differential diagnosis, and you can have a phenomenal treatment plan. You've got it. It's done. But if you can't convince that patient or that family member or caregiver who's making healthcare decisions for that patient to follow your guidance and to follow that treatment plan, all of your clinical brilliance means absolutely nothing. All comes down to your ability to communicate it.
All right. First off, I do want to confirm I'm a pediatrician because I have a Save the Children title. And I have Grover socks on today. Make sure that's clear. All right, so we're going to go into our origin story a little bit. So if you aren't familiar with us, we were at Kids Plus. I was there for 30 years. I was the CEO, as Andy said, for 12 years. Chad was our director of communications, our director of clinical services. Joyce is right there. And our CFO, Dr. Albert Wolf, we were all there together. We were really good in terms of communication, as you see it circled there in the bottom. And we think and absolutely attribute the fact that we were a top quality practice year upon year upon year because of what we did with communication. Yes, we were competing with $2 billion healthcare systems. We had 3 practices, 20 providers, and 100 staff. We certainly didn't have deeper pockets, but how do we continue in the clinically integrated network we were in with all these other practices, always at the top, leading or tied in every clinical category, and per lots of third-party data, the #1 HPV vaccinating practice in the state of Pennsylvania? Communication. It was at our core. It was woven through everything we did. And as Chad said, none of us, including myself, who went to Pitt Medical School, who did residency at Mercy, but tons of rotations over here, who even went back to school to CMU to get a Master of Medical Management, never had communication training. And it wasn't until this guy, who ended up becoming my communications coach for the year of 2009, that I started being exposed to communication. It actually all came from a 2009 article, Pittsburgh Post-Gazette. Mike, you'll like this. It said, "The Vaccine Dilemma." So big you could read it across the room in the paper, formerly Pittsburgh Post-Gazette. On the front of the picture was a mom holding, on one knee with her kid who was like 4.5, 5 years old, kind of not making good eye contact with the camera. And she goes on to tell you that he has a diagnosis of autism, and she's not sure if vaccines might not have played a role. You further read down into that article about the 2-year-old sibling, 2.5-year-old sibling, who also has a diagnosis of autism, who also had no vaccines. I almost erupted with anger. I wrote an op-ed, it got published. This guy made a comment on it, and I started realizing the power of communication, whether it was op-eds, whether it was media appearances, whether it was just talking one-on-one to a patient. Yet we have none of that training. That became integral to what we did. We ended up bringing him in full-time into the practice. That was the first communications director we know of nationally in a practice. So what I will tell you, and I think that we can talk about the further story that happened in 2017.
Go for it.
So here we are. We have a full-time communications director. I think 4 years after you were in there, we built out a full production studio. So we started podcasting, we started making videos, we started reaching our families in any way we could think, because we wanted them to have information anytime they wanted it, how they wanted it, where they wanted it, right? Because in 2025, it had already started back in the teens where people wanted their information like this. and they needed to be provided with that information. So in 2017, we made a video. It was called We Prevent Cancer. And because it was 11 years after the HPV vaccine had come out, and the NIS data from the CDC showed that only 37% of girls ages 13 to 17 had their full series for HPV. 11 years. 11 years. Think of that. That's 2/3 of girls going through doctor's offices and walking out unprotected. And you guys know the data, the vast majority would get infected. Not to mention boys who the vast majority, because they weren't really getting vaccines anywhere close to that rate. And so completely outraged, came back from an advisory board I was sitting on where they were talking about the importance of trust and how at that time, the data showed that people absolutely trusted their healthcare providers. And if they were able to connect with them with the right information, immense behavior change could take place. And in this case, it would be the uptake of the vaccine. So we made a video called We Prevent Cancer. In that video, 90 seconds long, public service announcement, every one of our healthcare providers, our docs, our PAs, and our NPs were on there, all with 5 or 10-second little clips, dispelling the myths that it only took as little as one encounter one time. It didn't require intercourse, it just required intimate touch. And we had data on all this. And it drove people to the phones. It's also partially what drove that #1 rating. But it also earned us, 3 weeks after that video, a global targeted online social media attack on our Facebook page. 10,000 attacks in 6 days. 2017. We used to say after that attack, like, this is a really sophisticated network. Holy crap, what would happen if there was like a pandemic or something? There was a pandemic. But we were going to HHS, CDC, who we were working with. We were going to AAP and saying, we need to be better communicators because it looks like we're going to, get the snot beat out of us. And we did. Anyway, we started telling this story all over the place. We actually did 4 things after that attack. 1, we went right over to the School of Public Health at Pitt and did research and actually got published in the Journal of Vaccine on that attack and did subsequent peer-reviewed research on the attack and talking about communication. The second thing we did was create an 80-page, Chad did this, an 80-page anti-vax toolkit on how to fight back, how to prepare, defend, and clean up after these attacks, which were inevitable if you were just going to stand up and speak for science. We actually took a page out of the book of the attackers, which, by the way, were every state in the United States, but then started coming from the Czech Republic and New Zealand and Australia and Italy. And we're like, holy heck, this is something really we've never seen before. By the way, guess how many attacks came from southwestern Pennsylvania? To the best of our knowledge, none. These weren't our patients attacking. These were people that had an agenda. You might know that that's now going on in 2025. The last thing we did was an awareness campaign. We were on the cover of the LA Times, cover of the New York Times, Science Times, 3 different documentaries, every major news entity, and peer-reviewed research journals. But Chad, that apparently doesn't resonate with your friends, family, or even academic partners until, yes, you were on People. So this actually is 4 years after the attack, because we never stopped doing the work of communication and dispelling inaccurate information. So as you can see, this was the Vaccine Warriors issue where they were talking about myth busting for COVID-19 vaccines. So much so that Chad said, not only should we be doing podcasting and creating videos and being on social media, you then said we need to be live streaming every week during the pandemic so that we can reach our families. And I guess we have a slide coming up that we'll talk further about that. But yes, and by the way, that is Chad's happy face. If you've been attacked.
That joke never fails to kill. I told you I'm from Philadelphia, so that's my resting face. But secondly, right, this was 4 years into fighting the anti-vaccine forces. That's serious stuff. This is my happy face at that point. All right, so we're going to make a few, we like to be bold. We're going to make a few bold declarations. First of all, and this was deeply implied in the comments I was making earlier, but evidence-based medicine and public health interventions do not work unless people trust the messengers. It is literally as simple as powerful, and who are we kidding, as frightening as that. Speaking back to the pandemic, imagine if we had a vaccine that was incredibly effective at preventing hospitalizations and deaths. And if we could just communicate well enough that everyone would take it, we could, oh yeah, that happened, except the second part didn't. Todd likes to talk to you, and he will in a second, about the idea of the industrial healthcare complex. Spoiler alert, you're all part of it. Second spoiler alert, it doesn't exist except in the minds of people who are trying to undermine every single thing that you all do every day.
Yeah. So Chad likes to use this line all the time, which is politics are local, but healthcare is local. What you will see in subsequent slides is the trust really exists between people and their healthcare providers. And anything we do that breaks that connection is going to weaken our ability to help people get to the right decision, the evidence-based recommended decisions. So
to illustrate that point, I have a little equation for you. That's not our math. That's the math of our patients and our families, and even people who weren't our patients and families in our community during the pandemic. We heard this over and over and over again. And Tony is a stand-in for lots and lots of other people. People told us straight up, in face-to-face, in person, in comments on our live streams, in emails and messages to our practice, we don't trust Dr. Fauci. We don't, and these are the people who are getting the vaccine, by the way. We don't trust the CDC. We don't listen to the World Health Organization. We aren't really paying attention to what the Allegheny County Health Department says. Him, you all, we trust. And if you say it, we're doing it. We weren't saying anything different than all those people that they told us they didn't trust were also saying. But they trusted us in part because of our longitudinal relationship with those patients and those families. And then the people who didn't have that longitudinal relationship, who were new to our practice or who were in the community paying attention and watching our live streams and seeing what we were doing, they trusted us because we were local and because we were communicating the hell out of the pandemic. I don't like to brag about much, but I will brag about that. The single greatest failure of the pandemic at every level, local, state, federal, was a failure of communication. We failed at every single level, from not reconciling one day's utterances and guidance with the next, with the way we demonized people who were questioning the vaccine. Also, I could go all day. The communication was terrible. We communicated the hell out of the pandemic, and people were paying attention, and they respected that, and they trusted that. And we told them what we didn't know, and we told them why we didn't know it, and we told them when we would know it, or when we hoped we would know it. And when we got to that point and we still didn't know it, we told them, and we told them why. And when guidance changed, we explained it very clearly. We trusted them to understand it and to listen to us in ways that no one else did. And so, yeah, like all politics, all pediatrics is local, all healthcare is local, and trust in everything, but especially in healthcare, is local, which is why that equation exists. So where else does the trust lie, Todd?
Well, a couple different places. So if you didn't know, year upon year upon year, data shows that people trust healthcare professions more than any other profession. Nurses at the top, doctors are not far behind. And if you break doctors down by specialty, pediatricians are right up there with nurses, which is very cool. So healthcare providers in general, you know, we're seeing trust drop in every category, including healthcare providers, but we continue to be at the top. But you see these other categories even lower, even journalists, Sith Lord, member of Congress. We did shamelessly steal this from Mark Del Monte, who's the CEO of the AAP. It's a great joke. But the key here is we have this precious asset, which is trust. Please don't undervalue it. You guys are still trusted. It doesn't mean you're always believed, but you're trusted. We just need the communication training to make the connection. Now, here's the deal. When we say healthcare providers, it can be any of these groups. It can be NPs, it could be PAs, dentists, it could be anybody that's in a position of trust. But it's not the insurer. and it's not the health system. I don't care how revered you are. I don't care if you're UPMC, Mayo Clinic, Cleveland Clinic, Kaiser. That's not where the trust is. The trust with, hey, that's Dr. Sally. That's my doc. Or that's Joe, my nurse practitioner. That's where the trust exists. And we need to get our heads around that. This data, do you want me to jump in this here, or do you want to take it? Yeah.
So the data, post-pandemic particularly, but even pre-pandemic, but especially post-pandemic, says that no one, as I said earlier, trusts anything or anyone anymore. You've seen the graphs for vaccination uptake the last 5 years. The graphs for trust look pretty much the same way. Declining trust in everyone and everything, even large concepts like science and medicine. If we can find those things, people don't trust them either. But what they do trust is my healthcare provider. They also trust themselves, which is something we could laugh about or argue over another day. Let's put that aside for the second. The other thing they trust, though, is their local healthcare provider, their own healthcare provider. And again, HCP all the way across the board, as Todd defined a few minutes ago. That is where the trust lies. Here's the good news on top of that. Trust in all of you may be the only thing in America on which all sides of the political spectrum in 2026 agree, or at least 2025 data, but we see no reason why 2026 won't be the same. It was also the same in 2024. When asked by the Edelman Trust Barometer in a massive national trust survey that they do annually, who do you trust to tell the truth about medical issues and protect public health? Respondents on the left, on the right, and in the center all chose my doctor, my healthcare provider, as the person they trusted, as the one source of trust that they had for those things. I cannot overstate this. That is incredibly, incredibly important. And we know, because we talk to folks like you all the time, we know how you feel watching public health and healthcare be systematically dismantled, both by people in Washington and 27-year-old influencers in the Midwest with lots of Instagram and TikTok followers. All of that is happening. But at the same time, this is still happening. This is still the antidote.
This is, we can't say this enough. This is where the solution is. This is the antidote to what's going on right now. This is absolutely where the trust exists. But right now, if you look at interviews of healthcare providers, regardless of if they're generalists or specialists, they're saying the same thing. Every visit's taking 5 to 10 minutes longer. Families that I've known are now asking questions they would have never asked. New families, oh my gosh. Healthcare providers themselves are feeling more harassed, targeted, and overwhelmed than ever before, not just to generate more RVUs, but now just to go into an exam room and to have a discussion that's evidence-based. So much so that healthcare providers are now shifting, and we've heard this interview upon interview, where we're shifting away from like presumptive recommendations regarding vaccinations. Hey, today, Susie needs her TDAP, her HPV, and her meningitis vaccine, something like that. Instead, we're having healthcare providers across the country, red and blue states, who are saying, I go in now and I just say, do you want any vaccines? Do you want to talk about vaccines today? That's akin to saying, Joey's 2-month visit was great. Thanks so much. Everything looks great. You could put him in the car seat facing rear, seat belted in, or you could put him up in the front seat with you around the hood. I mean, I don't want to make you feel bad. Right? And that's the laughs we always get when we give this presentation, but that's what we're doing. Like, do you want to talk about vaccines? Because we as a profession are risk adverse. We're conflict adverse. People generally love pediatricians. I'm wearing Grover socks, damn it. It was kind of this thing that was beautiful about pediatrics. It's the reason that I went into it. It was just the relationship we have with our families. That relationship is still possible. Yes, the vast majority of your patients are now coming into your exam rooms, clinics, pharmacies, whatever setting you're in, now more likely than ever being impacted by inaccurate information. But they still trust you and they want to hear from you. We just need to be better prepared on how to tackle it. And what I will tell you is your training to this point is going to fail you. You have not been trained on how to communicate, nor on how to be immersed in 2025. That is completely changeable. And it's part of what we're going to talk about, but it is critical because if you don't, you will feel more harassed, you will feel more disconnected, and your patients will feel more disconnected from you.
We told you before, we will tell you again, good communication is essential to good healthcare. And we will also tell you all the way back to, I don't trust the World Health Organization unless Dr. Wolynn tells me on a live stream, we're not failing at the science. We're failing at the communication of the science. That is the problem. That is also the solution. But as Todd just said, you aren't trained for that. You're trained for these things. Well, you aren't trained for these things.
Look, the villains when I was in medical school at Pitt were viruses, bacteria, and malignancies, right? That's what I had to learn. I had to remember which was like coagulase positive and negative. Why do we have to know that? But we had to memorize that, right? Like that was part of it. I keep looking at Andy because that's what ID people made me do. But Mike, you too. No, you're not getting off on this. But yes, I mean, that's what we did. But none of us were trained for this. None of us were trained for trending, news or algorithms. That's the world we're immersed in. If you look at it, this is the stuff we got thousands of hours, right? Thousands and thousands of hours from my stethoscope, Brian Feingold, right? So I could listen to murmurs and rubs or maybe some rhonchi, and I could diagnose things between here and here. Yeah. Or otoscopes. Yes. I had to do inter-observer reliability with Dr. Bluestone on the early tube study. And I had a pneumatic otoscopy, everything with Phil Kalida. And yes, I got thousands of hours of learning how to use those devices. I could either diagnose stuff here, or here. I got 0 hours on my communicoscope, which I use in every intervention, every visit, every portal message, every email. Every time I connect with somebody in any way, I'm communicating, though no training. Oh, you went to college and nursing or medical school or pharmacy, you go communicate. We weren't taught on how to listen, how to think, and how to talk. And again, our instincts fail us, and we are going to show you exactly how. So, rhetorical?
Yeah.
You're not. All right. Here's he did. Okay, ready? You guys, I think you're ready for this. You want to? Okay.
Shout it out when you got it.
That's right. Pheochromocytoma, an incidence of 2 to 8 per million. But even I, when I take boards, have to still prepare for this question. I am never likely to ever see one of these again. And unless you work in a quaternary, maybe tertiary center, you're not going to see it. And if you see it and you don't know it, you don't even need AI, Suresh, to put a good search in. You can use a good old-fashioned Google search, and that's going to pop up #1 in your differential. Why are we being forced to study for minutia? Because our old curriculum is such that you gotta, everybody has their turf, the neuroendocrinology people, the renal people. I have nothing against any of these people. I'm just saying, but we're not being asked to prepare for communication. We are graduating people now. Now, let me take you back. When I graduated, 92, I was pretty well prepared to deal with making diagnoses, matching up the right thing, getting people to the right place they needed to be. Maybe I was 95% effective as a graduate, at least being prepared. I'm going to argue that people that are graduating now are probably 60 or 65% effective. Think what's happened in those years since I graduated. Technology's gotten better, information's gotten better, able to search information's gotten better. So you have way more information. The problem is we now connect worse with our families because of our current training. So yes, this change has to go all the way upstream. Nursing schools, pharmacy schools, medical schools, PA, NP, it all has to be improved. Now, you probably didn't think about your careers this way, but I would argue this is what you do. The majority of your job is about behavior change, trying to get people to do more of some of these or less of some of these. We aren't taught about this. We just kind of think like, I usually make the reference to Dr. Welby from the 50s. That won't mean anything to you, but it's like doctors will say stuff or nurses will say stuff and people would just do it. Now that's less true than ever. It probably wasn't even that true back in the 90s or 80s, but for sure now you cannot take any of this for granted. You have to be amazing at behavior change. What changes behavior, Chad? Maybe communication. So, want me to take this one? Yeah. Okay. Thank you. Let's use general practice. Again, I was the CEO of Kids Plus Pediatrics. We were really effective. I'm going to use immunizations as an example of something that we did, that the AAP espoused, that CCP and AHM practices did, which is what I describe as operational best practices. When you did these various AAP echo modules and you did the various modules to show PDSA cycles, you could start seeing that if you increased access or if you used EMR prompts or had huddles in the morning to reduce missed opportunities, you could drive up uptake, in this case of immunizations. I describe that as tactical operational changes. I think all of the practices were doing that pretty well or getting better at it each year. But what we did differently, and I think what put us at the top across every category for quality, was communication strategy, which we wove communication again into everything we did. We made sure parents were able to connect down to the level with a provider, or at least to the level with a practice, on anything that was in their mind. Maybe it was car seats, maybe it was sunscreen, maybe it was immunizations, but we always wove communication through with training of our individual providers, as well as any platform you could think on. We were there in a way that was relevant at a local level. I'm going to throw some shade here right now, can I? I'm going to. If CCP has 75 practices, but only one Facebook page or only one Instagram page, how effective and relevant do you think that is to the families that pull open that page? And this is true of Kaiser and Mayo and every other system. I'm not just throwing shade at UPMC. Every big system, and it is the truth that things are going this way, get bigger, right? We kept hearing that, merge, integrate. Well, that is the reality of the world. The problem is that through economies of scale and corporate communications, they're like, well, we could save money and just make one Facebook page. The content's rich, right? It's valid, but you don't get to see Dr. Joe or Pat, my PA. And so what you have is some talking head CMO up there people don't know, they don't equate to. And frankly, I think it's kind of hard to feel kind of warm and fuzzy about your health system that's building $1 billion new wing to a new hospital a few miles away when I can't afford my premiums and I can't afford my deductibles. I'm just telling you, this is the reality. So can you decentralize? Should we decentralize social media back down to the level, at least, of the practice? Yeah, because that's what people want to hear from. Because if you're not there, they're totally going to disregard the corporate communications that they're getting. And guess who they're going to listen to? This person's in my running group in Facebook, and they said these crystals are really effective at preventing disease. And there's a notion, a psychological term that's called tribalism. I don't even know that person, but they're in my running group in Facebook, so I kind of trust them. Or that person in my crochet group on Instagram, she said these oils are really effective and I might not need to vaccinate. But your practice is nowhere for them to connect to. They want to hear from you. They don't want to hear from the CMO, and thus we abandon them. Yeah.
Want to bring us back to tactics versus strategy for a second. We'll let Todd cool down about social media. And you didn't use your line. That's how you take the social out of social media. I was waiting for it. He built up to it and he missed it. He was hyperventilating. All right. The difference between operations, between tactics and strategy, is incredibly important. Because Todd said, everybody knows to do the stuff on the left. And so they do it. Check the box. We do it. We do it. There's a very large difference between doing something and doing it well or doing it optimally. And you can do those things and have little to no effect. Case in point, you heard from our intros that for a while we were working for the largest pediatric and largest pediatric entity in America, the Pediatric Associates, 300 plus clinics, several thousand providers, 7 states. I was running comms for them. And in the state of Florida, they were all over Florida, having issues with well visits and with asthma med regulation with their asthma patients. And so they talked about doing SMS and email campaigns. And, oh, yeah, we do them. And we were like, okay, let me look at them. They were terrible. It was like people who didn't know how to use the English language had written them. And so we came up with a new schedule, a new cadence. We didn't send the exact same terribly written message every single time. We had ones that built. We used communication, rhetorical principles with grabbers and good calls to action. And guess what? Within 3 months, we closed gaps by 25% in both categories, just simply by adding some actual strategy to the tactics that we were doing, by adding communication to the clinical operation best practices that were already there. It's very much, again, about that communication.
I'll say one more thing. You know how your training also fails you? Think about every lecture that you had through medical school, nursing school, pharmacy school, whatever. Heavily bulleted, lots of text. And let's talk about 37.6% of patients, right? Why does everybody love a TED Talk? Because they're engaging, because they're educational, and they're entertaining if you're doing things right. Serious learning doesn't have to be boring. It's why all of you doom scroll on TikTok and Instagram, and you know what a good 30 seconds or 60 seconds looks like. That is what everybody is out there, their own discerning customer on what communication is. We aren't taught that way. Yes, this goes back to now we have shifted from a fee-for-service world, meaning you're being paid for everything you do. So no more just paid for a swab or paid for a urine or paid for an x-ray. We are now being paid on value-based care. Value-based care is at a population health level. Yes, you can still drive results with one-on-one conversations and that exquisitely precious time in the exam room, but that's not scalable, which means you have to be using population communication to drive population health. And so we see now that we're shifting to this world. That makes communication even more important. And as you can see, we are losing the battle. If you look across the board at quality metrics, including vaccinations, in spite of all the campaigns we've done over the years, numbers are dropping. We have not recovered from the pandemic. In many places, very few things are even staying still. They are dropping. We have no strategy in place. Even though we've been saying this since 2017, we are not being trained or prepared. You literally are being sent out there into a battlefield unprepared. You were bringing a stick to a really nasty automated fight. Okay, so it's going to get better. We have positive things to say. Okay, so yes, communication strategies are absolutely the antidote that we need. All right, there are two healthcare communication training fallacies that we fall into. Outside of that door, 365 days a year is the real world. Inside this door is inside your office, your clinic, your pharmacy. We are trained like the only important information that's going to be exchanged is always going to be face-to-face. The only training I really got at Pitt Medical School was these mock patients. If you saw Seinfeld, there's a good episode you should watch about it. But basically, it was just like, that's the only communication. Somebody's going to come in and I'm going to have to, ask them questions and learn how to make diagnosis. Never really learning how to make good communication there. But that's not how the real world works anyway. People aren't waiting 5 months for their next visit to ask you their 4 questions. They're going on that night to find the answer, or that moment to find the answer to the question they have. And if you, their provider, are not here in some shape or fashion, they will get it from somebody else who did not take an oath to do no harm. The other thing is, yes, you're trusted, but you may not be believed. That's a bummer. What that's called is debunking. You are now in a situation where you're kind of on the defensive and you have to explain to them what they understand to be true is not true. It is the worst of the situations that you can be in because they are affected deeply and it's not an easy recovery, but it can be recovered. What is the right and best and evidence-based approach is pre-bunking. Have anybody heard that term? No, because we aren't taught research. Pre-bunking is getting people the right information at the right time that is accurate before they're impacted by inaccurate information. With that, the data actually shows that it acts like an inoculation or an immunization where they are less willing to uptake or more resistant to uptake inaccurate information. So heading into respiratory season, we could get ahead of that a month or two and start telling them about the real facts about things like flu and RSV and COVID. But we aren't taught to think like this, and so we're always on the defensive. We're always playing whack-a-mole. There are 2 absolutely essential ways that we engage people. One is face-to-face. That is precious. It's not scalable, but we really need to be in a much better situation when we are talking to people in this face-to-face setting. But the scalable is obviously using digital tools to do so. If you haven't heard of it, there's this thing called social media. It's out now. It's pretty big. It is the most powerful communication tool. It can create wars. It can create genocide. It can create entire populations to do all sorts of different behaviors. Every other sector in the economy has figured this out. That's 1 year, 1 hour, that little wedge you see of face-to-face time. We don't get that. We don't get an hour of face-to-face time per year with our patients. And that wedge is actually too big, but I had to make it big enough for you to see. But these companies don't care. These companies don't care if they get face-to-face time because they've figured out that they can use communication to change behavior. I can get you to pay $12 for your double pump mocha latte with the right nudges and the right information on various tools. I can get you to take a cruise or buy our streaming service. Every other sector of the economy uses communication to get people to do things. And we haven't. Healthcare is the largest sector of the economy. You guys have never been trained on using communication powerfully, whether digital or face-to-face. And we are getting our butts handed to us because of this. So these corporations and plenty more recognize what's called a positive ROI, return on investment. For every dollar spent, and they spend hundreds of billions of dollars collectively on those efforts, they get more than $1 back. They are willing to invest heavily into communication, face-to-face when they have the opportunity, when people come into their stores, whether it's services or products, or digitally. And we've gotten none of that training. We're literally not hucking tires or insurance. We're trying to keep families healthy. We're trying to keep kids from being infected, or if they have heart disease, how to comply with a medication regimen or an exercise regimen that's going to keep them healthy and allow them the best quality of life. And we haven't figured out to use the most powerful tools in the world. This is a real issue because when you talk to health systems that employ the vast majority of healthcare providers in the United States and say communication is really important, they unfortunately conflate marketing with communication. When I look at these systems, websites and social media sites, they talk about, we're ranked number 4th nationally for this category. Check out our new billion-dollar investment in genetic therapies or our new robotic surgery. Who's the audience for that? Do you think your patients care about that? Do you think they care about the new billion-dollar wing on a hospital? They don't. They want to hear what, Dr. Green has to say about something, or Dr. Jones, or Sally, my PA. They don't care about being marketed to. The audience for this is the C-suite, it's shareholders or a board, so they can say, yeah, tout all that real expensive stuff we do. When somebody who's living in Wilkinsburg or over in Shadyside just wants to hear like, hey, I see the government saying that I don't need a rotavirus vaccine for my kid. Is that right? Well, they don't get to hear from Dr. Joe or Pat. Why not? Why not? This is absolutely why our butts are being handed to us. So marketing is very top down. If you do communication right, it meets people where they're at. Yes, there's issues with literacy and cultural relevancy, but good communication meets people where they're at and it's bi-directional. Yeah. All right, I'll take you through this quickly, which is basically, if you're looking for the biggest impact on healthcare, it's not the big spends. Social determinants, that's pretty good, but behavior change, that's where it's all at. And we change behavior with trust, which we have, and good communication.
So if we're about changing behavior, it's got to be about how people make decisions. And we have healthcare decisions, but it's how people make all decisions. What we'd like to think, particularly those of us who work in medicine and science, that people make decisions with the intellect, basically from the neck up, except they don't. Virtually no one does. Even people who are steeped in this, who are trained in it, all of you, how many of you have ever in your lives done something that your brain was telling you not to do, but some other organ below your brain was telling you to do it anyway? Anybody who didn't raise their hand is lying. Either that or you're an android. If you're a human, you've done that over and over and over and over and over again. Where people do make decisions, including their healthcare decisions, and yes, of course, they should be making them up here, but they don't. They make them from the neck down. They make them down here. Their values, their beliefs, their fears, their emotions. It's very much an emotional, a visceral response, not an intellectual response. So when HCPs and public health trusted messengers say things, we often do one of two things. One is we go very heavy on data. This article in JAMA and 95% confidence intervals and all of the studies, and all of which comes in this year and out this one. Or we default to fear, which might seem like a good idea because I just said that fears and emotions are one of the things that people use to make decisions, except, do you know how many people got sick last year? How many hospitalizations there were? Do you know how many children died of the flu last year? Why? Because you can't scare someone out of being scared of something else. And you can't statistic them out of it either. And so, again, it's what you're trained to do. It's what you default to, and both of them actually make things worse. There's really good data that says when people have emotional responses to something and you meet them either with a different emotional response or with data, they actually dig in their heels. It actually entrenches their resistance to what you are recommending. So, no fear, no data. Of course, the data is very important to base all of your decision-making on, but not your persuasion. Just wanted to clarify that. Mentioned that guy from a couple of millennia ago who's a communication theorist named Aristotle. Dude was a genius if he didn't realize that. He had it all figured out all the way back then. Our legal system, pretty much all of our dramatic and entertainment, and this stuff too. Really quick Aristotelian rhetoric. Neck up. That's the logos, the logic, the fact, the data, the evidence, all the stuff that's really, really important that the fewest people pay the least amount of attention to. Then there is the pathos, the emotional, visceral response. That is the most powerful way to persuade someone. The second most powerful way to persuade someone, luckily for all of you, is ethos. And that is the character, the credibility, the reputation of, or the trust in the messenger, the speaker, the persuader. So there are things you need to avoid, but if you avoid the triggers, and you get better techniques in communication, you can cut through everything that's below the neck.
Now, I'll take you very quickly through a training you've never had. First off, you've never had that training that you just heard before about how people make decisions, which is why we're set up to fail when we go in and we want to prove them wrong. You can't get flu from the flu vaccine. It's inactivated. There's no possible way. And you want it, once they understand that they're wrong, then they'll buy in. No, their decision was made here. Hey, I heard government, pharma, and doctors are all in bed with one another and they're trying to make me sick, right? You can't overcome that by saying, no, that's not possible. This is training that you also did not receive. This is an evidence-based communication methodology called AIMS. And yes, is there a place for data and even some of the scary stuff after you've managed to get through this? Yes, and we'll talk about how. So A stands for the presumptive announcement. This is called AIMS. So yes, Mrs. Jones, Susie needs her TDAP, her HPV, and her meningitis today. She's 11 years old. Her exam was great. Let's go ahead and get those done today. Not, do you want to talk about vaccines? I don't know, Doc, do you? Because you don't seem pretty convinced about it. So I make a presumptive announcement. Mrs. Jones might say, yeah, absolutely, let's get it done. As a matter of fact, the vast majority of people will say, let's go get it done. Right, center, and left, people want their kids immunized. People want to be immunized. That is the truth. No matter what you're hearing right now through the webosphere, the majority of people want it. So we need to be confident about it. That does not provide room for her to say, you know what? We live here in Pennsylvania. We'll get the TDAP one and that meningitis one. She needs that for school. HPV, I want to hold off. Inquire sincerely. Mrs. Jones, I absolutely want to know, what are your concerns around the HPV vaccine? Then, as Chad likes to say, shut up. Let Mrs. Jones talk. We have a horrible habit, because I'm rushed to get to the next patient, of interrupting our patients, but let her explain what's going on. You may have to ask an additional question, but in the end, she may tell you, you know, my sister-in-law posted on Facebook that HPV vaccine, that's the one that sterilizes kids. Mirror. Mrs. Jones, I want to make sure I have this right. It was your sister-in-law that posted on Facebook that the HPV vaccine can cause infertility or sterilization. Do I have that right? That small maneuver literally changes the whole psychological dynamic of that visit. She goes from being in a kind of sympathetic fight or flight, you're going to judge me, you're going to belittle me, you're going to demean me, to, oh, you're listening to me. Oh, you're demonstrating active listening. You've just mirrored exactly what I said back. You now know what scares me. I now know you know what scares me. That is a completely different dynamic. It kind of puts them into a parasympathetic mode, ready to digest both mentally and down here. And now I want to hear a little bit more. Now I can start doing things like express empathy without magnifying the myth. If I thought that that could cause sterilization, that'd scare the hell out of me too. I could understand why you want more information or why you're concerned. And then be genuine and say, can I tell you why I'm so passionate about the vaccine, why I got it for my kids? Or if it was flu or whatever, why my wife and I got it, or why I recommended it for my parents or my grandparents or my nephew or niece or neighbor, whatever's authentic and real. Now you have a discussion going on. Now you can talk about some data. Now you can even talk about some scary stuff. Last year was horrible for flu. We hadn't seen a year like that in over a decade, because now I'm not using it to railroad them or steamboat them. And now they feel that I'm on the same side of them. By the way, the goal of this is not to make somebody do what you recommend. The goal of this is to build trust. So that if you get down to the last step and she says, you know what, let's just do the TDAP and meningitis today. I want to go home and talk to my husband about the HPV vaccine. I thank her. I secure the relationship, whether she says yes or no. And I say, thanks for just taking time and explaining to me what was concerning to you. Thank you for letting me talk about what was important to me. I'm passionate about this. I'm going to bring it up at future visits because Susie's health's that important to me. You don't have to abandon the science. You don't have to abandon having conviction around it, but you have to know how to get to a place where we can access this without being a threat. It is critical. You are not taught this. It is why we're set to fail.
Take it from here.
Okay.
So I want to underscore 2 points that Todd made that are incredibly important. It's the transition that makes everything work. Number 1, the expression of the empathy. And we sometimes get pushback, and he mentioned that of, oh, aren't I just validating that stupid conspiracy theory? No, you're not. What you're validating is the emotional response to it, which is so incredibly important because, again, that's where people are making their decisions. And when you validate the emotional response to the bullshit, you have to remember that the emotional response is valid no matter what it's based on. And even if it's based on a conspiracy theory, doesn't change the fact that the fear is real. So that empathy is incredibly important. That would scare me too if I thought that. Incredibly important. And then number 2, that asking of permission. Because Todd said they're ready. They're ready to be judged. They're ready for you to come with the fear and data. And it's just like, you empathize and then, okay, now here comes the fear and data. No, it's, would you mind if I told you, or may I talk to you about, may I tell you why I give this? Totally changes the nature of the relationship. It's building that trust and building that confidence.
And I'll say one last thing. You might think that takes a little extra time. It really doesn't. This is not motivational interviewing. It doesn't take 5 hours. And Andy Nowak's, one of his great lines from the most recent podcast he was on is, you have no idea how much time bad communication takes. You can build upon this. Even if the answer is we're going to go separate ways on this, they now trust you to be more open on subsequent visits.
And it saves you time on subsequent visits too. All right. So to wrap up, again, we need to reach people where they are in the exam room and online, but also where they are emotionally, where they are communicatively, rhetorically. Because if we do that, that's when we change behavior, and that's when we drive healthcare outcomes. I can't stress this enough. We talk a lot, and we've talked a lot up here. You all talk a lot about people being in their bubbles, in these things, and they are. Trigger warning, y'all are in your own bubbles too. And it's incredibly important to remember that, because a lot of the disconnect between how we talk from our bubble to people in the other bubble fails because we talk to the people in the other bubble as if we're talking to the people in our own bubble. Public health is much more guilty of that than healthcare providers, but everybody does it. Meeting people where they are means getting out of our own bubble, understanding them, why they are where they are, and then trying to meet them, not validating, but meeting them there and empathizing with them. So we're trying to build a bigger tent. And we know, yes, and we had that vaccine attack. It was extreme left and extreme right, everywhere in the middle, but the 2 biggest boluses of attackers and anti-vaxxers were far left and far right. Truly anti-vaccine, anti-science, you're not going to convert them. You're not. We're willing to just discount them because they're an incredibly small, incredibly vocal. They punch way above their weight, but they're incredibly small percentage of people. We need left, center, and right. That earlier graphic, people who are willing to meet in the middle. And that's where we are going in the work that we do. And that's where we were urging all of you to go as well, to keep, as much as your own self likes and believes in a partisan political agenda, I'm going to beg you to keep that shit out of the exam room. Because that's never, ever going to make anyone listen to you who wasn't going to listen to you already. But it can sure as heck make people who might have been predisposed to listen to you turn immediately away. It is a no-win, possible lose situation. So calls to action.
Very quickly, everybody can get behind good health as a unifier, right, left, center. People want to be healthy. They want their kids healthy. You guys already know now. You're trusted. That trust can help empower healthcare providers with good communication. And when we're empowered and we feel more confident, our patients become empowered. They feel more empowered to share. We need to do this in two formats, both in person and online. As we said, communication is an incredible, powerful change, a changer of behavior, and it's absolutely a new path forward. If you're looking for CME on this, including the AIMS, this is a free module for MDs, DOs, RNs, PAs, NPs, and pharmacists. This is on our website. It can take you right to the training. It's better than another hour of constipation. I'm sorry to anybody who's GI out there. So yeah, check that out. And we also have a podcast that is a weekly podcast. We have a guest already in the audience here, and we have a lot more coming. The guests on there are going to be from around the country, from a variety of areas, including healthcare and public health, but also outside. We need to learn from other sectors. And with that, we'll answer any questions. Thank you very much.
Thank you.